Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. How are your hormones feeling today? Mine feel great. Well, that's good because today's lecture is on pituitary and thyroid drugs. Now, this can be an intimidating subject. There are multiple hormones that affect other hormones that affect other hormones, and you have to get it straight in your mind because it can get confusing pretty quickly. But let's get started. First, let's do an overview of the neuroendocrine system. Now, release of hormones can be initiated or inhibited by the nervous system, and some hormones can stimulate or inhibit nerve impulses, and that's why we call it a neuroendocrine system. Now, it's controlled by the pituitary and the hypothalamus, and we'll go back over and over again through the process of what is secreted by the hypothalamus, how does it affect the pituitary, and how does that pituitary hormone affect the rest of the body. Now, the pituitary consists of two parts, the anterior and the posterior, and it rests at the base of the brain. The pituitary is connected to the hypothalamus by a stalk of neurosecretory fibers and blood vessels, and this also includes a portal venous system that drains the hypothalamus and it also perfuses the anterior pituitary. Now, this portal venous system can carry small regulatory hormones from the hypothalamus to the anterior pituitary. Now, response time varies from seconds to days and can cause responses that can, again, last for minutes, but upwards of weeks as well. So let's talk a little bit more specifically about hypothalamic and anterior pituitary hormones. So in general, hormones from the hypothalamus are low molecular weight proteins, and they bind specifically to receptor sites on target tissues. Now, the hormones from the hypothalamus regulate the anterior pituitary by using the hypophyseal portal system, and that's what we talked about before with the portal venous system. They are described as either releasing or inhibiting. The releasing hormones from the hypothalamus will cause an activation of genes that promote the production of protein precursors, and these are then processed post-translationally to the hormones that are then released into the circulation. Now, precursor proteins like vasopressin and oxytocin are produced in the hypothalamus itself, and then they are transported to the posterior pituitary where they are stored. Now, the anterior pituitary, which we'll talk about mostly first, their hormones are not stored, and that's an important test question. Posterior pituitary can be stored, anterior pituitary are not stored. Now, the hypothalamus releasing hormones are used mostly for diagnostic purposes, and we'll talk about this in more detail later. And most pituitary preparations are used for specific deficiencies rather than treating any other major medical problem. Now, another important fact is that most of these drugs are administered IM or intramuscularly, sub-Q, subcutaneously, or intranasally. Now, they're not orally given most of the time because of their peptidyl nature. It makes them very susceptible to destruction by proteolytic enzymes of the GI tract. So our first drug is adrenocorticotropic hormone, or this is also known as ACTH. It's also known as corticotropin. Now, this hormone is released from the anterior pituitary. That's a good distinction there, anterior, not posterior. First, you need to start in the hypothalamus. This is where corticotropin releasing hormone, or CRH, prompts the release of propiomelanocortin. Now, ACTH is the product of the post-translational processing of propiomelanocortin. Now, ACTH is released from the anterior pituitary and pulses with a diurnal rhythm. The highest levels are at early morning, about 6 a.m., and the lowest is found in the p.m. Now, stress tends to increase secretion of ACTH, and there's a negative feedback effect which is produced from cortisol. So let's talk about where ACTH goes. So ACTH targets the adrenal cortex, where it stimulates adrenocorticosteroid synthesis and release of adrenocorticosteroids and the adrenal androgens. So ACTH binds to receptors that stimulate G protein, which leads to an increase in cyclic AMP, which activates desmolase. Now, desmolase will convert cholesterol to pregnenolone, and this pathway ultimately ends in the formation of cortisol. So let's review. So CRH will, from the hypothalamus, will stimulate release of ACTH from the anterior pituitary, which will then stimulate cortisol production and secretion from the adrenal gland. So let's talk about some of its therapeutic uses. Because of a low availability, there's limited use of synthetic ACTH. Primarily, it's used as a diagnostic tool for differentiating between certain types of adrenal insufficiency. So primary adrenal insufficiency, you'll hear about this. It's referred as Addison's disease, and its primary problem is an adrenal atrophy. Secondary adrenal insufficiency is caused by inadequate secretion of ACTH by the pituitary. And tertiary adrenal insufficiency is an abrupt cessation of exogenous steroids. Like if you're giving someone steroids long-term for asthma and you stop those steroids relatively quickly. Also, the drug of choice that's used commercially is Cosyntropin, and that's usually what you're going to use for these diagnostic tests. So ACTH has been used to treat infantile spasm or West syndrome. For its adverse effect, it's similar to those of a glucocorticoid. So basically, if you're giving ACTH, you're stimulating the body to produce more cortisol. And what are the effects of cortisol excess? So it results in Cushing syndrome, so central obesity, moon face, hirsutism. Next, let's move on to growth hormone, also known as Somatotropin, or there's another medicine called Somatrem. So this is a large polypeptide. It's released from the anterior pituitary. So remember that, not posterior. This is anterior again. Growth hormone, releasing hormone, GHRH, is released from the hypothalamus, and this promotes growth hormone release. So let's review. So hypothalamus affects anterior pituitary. So growth hormone releasing hormone affects growth hormone. So it's inhibited by somatostatin, and we'll talk about that here in a little bit. So GH, or growth hormone, is pulsatile with its highest levels during sleep. It decreases with age and is accompanied with decreased muscle mass. It's responsible for bone growth and is needed to attain normal adult size. So growth hormone is primarily mediated in the peripheral tissues by insulin-like growth factors 1 and 2 in the body. So growth hormone doesn't always exert its effect itself on the body. It uses insulin-like growth factor 1 and 2 to do it. Let's talk about the therapeutic uses. So this is used for growth hormone deficiency in children. And there are some criteria for growth hormone deficiency. So one is growth rate below 4 centimeters per year. And 2, there's no serum growth hormone response to 2 growth hormone secretagogues. So therapy with growth hormone fortunately can achieve normal adult height in children who have growth hormone deficiency. Now, it's also used to treat short stature in Prader-Willi syndrome and in Turner syndrome. It's often used in AIDS patients to treat wasting. There are some controversial uses for this medication. So in children with idiopathic short stature, so they don't actually have a growth hormone deficiency, but they're just really short. They must fall below 2.25 standard deviations for height. So they're, quite a bit further below their peers in height. Even more controversial is used as an anti-aging drug. So anti-aging programs will use growth hormone to develop muscle and lose adipose tissue. Weight loss programs are now starting to use growth hormone to help lose weight. Athletes will use growth hormone to develop muscle mass, and it's been banned by the Olympic Committee. Adverse effects, well, very rarely you can get serious problems like intracranial hypertension. More commonly, you can get some edema or some myalgias or arthralgias. It's contraindicated in patients with closed epiphysis or a malignancy. Next, let's switch over to growth hormone inhibiting hormone. So again, we were just talking about growth hormone that was promoted by growth hormone releasing hormone. So now we're talking about the opposite, growth hormone inhibiting hormone. And this is also called somatostatin. So it acts on the anterior pituitary to inhibit growth hormone release. So it's released from the hypothalamus. Also, it can inhibit release of TSH or thyroid stimulating hormone. It can inhibit insulin, glucagon, and even gastrin. It's found in the hypothalamus, as we just mentioned, but it's also found in other things like neurons and in the intestine and in the pancreas. So the 2 medications we use most often are called Octreotide and Lanreotide, and they are the synthetic forms that have longer half-lives than endogenous somatostatin. So let's talk about the therapeutic use of these medications. Well, first is pituitary excess, things like acromegaly, an ACTH secreting tumor. It's also used in GI endocrine excess problems like VIPomas, Zollinger-Ellison syndrome, carcinoid syndrome, glucagonoma, and insulinoma. It's also used in certain diarrheal diseases. And also, you can use it for to help reduce splanchnic circulation for problems with portal hypertension. So if you have bleeding varices or bleeding peptic ulcers, you can use this medication to help decrease that bleeding. Pegvisomant is an analog of growth hormone. It's also used to treat acromegaly if somatostatin or octreotide is ineffective. Cabergoline is a dopamine agonist, and it can also inhibit growth hormone secretion. Adverse effects include nausea, vomiting, abdominal cramps, flatulence, and steatorrhea. Gallstones can occur after long-term use of these medications as well. Next, let's talk about gonadotropin releasing hormone. It's also known as luteinizing hormone releasing hormone. Now, this is formed in the hypothalamus. Pulsatile secretion promotes release of follicle-stimulating hormone, FSH, and luteinizing hormone, LH, from the pituitary. Let me repeat that. Pulsatile secretion promotes release of FSH and LH from the pituitary. Now, conversely, continuous secretion will inhibit gonadotropin release. So, pulsatile promotes release. Continuous secretion inhibits release of the gonadotropins. It can be administered sub-Q, IM, and by a nasal spray. The medications we use are called Leuprolide, Gocelerin, Neferalin, Histrelin. Now, therapeutic use so if you want to stimulate a gonadotropin release, so for, say, female infertility, though it's not very commonly used, most use the actual gonadotropins. Though if you're going to use these type of medicines, there is a less worrisome chance of multiple pregnancies. You can also use this for male infertility, but again, it's not as commonly used because the gonadotropins directly work on this problem a little more effectively. So say if you want to do suppression. So how do we do a suppression? Well, you have to give continuous use. And you can use this if you want to suppress gonadotropin. So the diseases where you want to suppress the gonadotropins, well, say in endometriosis, you could use these medications. In prostate cancer, if you want to decrease gonadotropins to help treat that. And then in central precocious puberty. So someone is having an uptick in their hormonal activity and they're too young and we need to suppress that. So adverse effects: dermatitis, headache, hot flashes, sweating, diminished libido, depression, ovarian cysts. It's contraindicated in pregnancy and breastfeeding. Next, let's talk about the gonadotropin. So this is LH, luteinizing hormone, FSH, follicle-stimulating hormone, and HCG, human chorionic gonadotropin. So these are glycoproteins, and they're produced in the anterior pituitary. So anterior, not posterior, not hypothalamus, anterior pituitary. And they regulate gonadal and steroid hormones. So luteinizing hormone. Well, what does luteinizing hormone do? Well, an acute rise, as you'll remember, will trigger ovulation and development of the corpus luteum in females. In males, it'll help stimulate production of testosterone. Follicle stimulating hormone, what does it do? Well, in females, it helps initiate follicular growth. In males, it helps stimulate spermatogenesis. HCG, human chorionic gonadotropin. So in females, it maintains the corpus luteum during the beginning of pregnancy, and which causes it to secrete progesterone. It's also very similar to LH, HCG, and can also induce ovulation in females and promote testosterone production in the testes in males. So let's talk about some of the medications that have been developed so far. So there's one group called the minotropins, or we call that HMG. And they're the first commercial gonadotropins. They were produced and extracted from urine with FSH-like properties, but it also had some LH properties as well. But it only had a potency of about 4% of the properties of FSH itself. Now, there's more purified versions of FSH that have been produced. There's one called urofallotropin, or UFSH, and there's two recombinant forms called fallotropin alpha and fallotropin beta. Now, there's recombinant forms of LH called lutropin alpha, and there's a recombinant form of HCG called choriogonadotropin alpha. So therapeutic uses, so infertility in general. So women, if you give the HMG or FSH over a period of 5 to 12 days, this can cause ovarian follicular growth and maturation. If you give a subsequent injection of human chorionic gonadotropin, then you can cause ovulation. In men, you can give HCG, which can cause external sexual maturation, and then with a subsequent HMG, the Gonadotropin, then you can cause spermatogenesis. So adverse effects. Well, one of the big ones is ovarian hyperstimulation. So about 0.5 to upwards of 4% of people can have this problem. It can result in ovarian enlargement, ascites, hydrothorax, and hypovolemia, and sometimes even resulting in shock. Now, when it gets to that severity, obviously the percentages are much, much lower, but it's still a worrisome thing to have to deal with. Multiple pregnancies, so 15 to 20% of these patients will have a multiple pregnancy. You can also have problems with headache, depression, edema, and precocious puberty, and gynecomastia. Next, let's talk about prolactin. Now, prolactin is a peptide hormone. It's similar in structure to growth hormone, and it's secreted by the anterior pituitary. So, not posterior, not hypothalamus. This is anterior pituitary. Now, it's inhibited by dopamine. It stimulates and maintains lactation. That's its primary function. But it also will decrease sex drive and will decrease reproductive function. Now, this makes sense because after a woman has a baby and she's breastfeeding, it decreases her, first her sex drive and also her reproductive function, so she's not immediately getting pregnant again while breastfeeding. So it's a natural contraceptive. Now, prolactinomas, so things in the brain that shouldn't be there, so a tumor that's secreting prolactin can cause amenorrhea, which is obvious because that's its primary function of decreasing reproductive function. But it can also cause vision changes and headaches. So if you get a question about someone who no longer is having periods and they have blurred or double vision and they've got headaches, then you need to think of prolactinoma. Now, for hyperprolactinemia, what type of symptoms are patients going to get? Well, basically the same things we've been talking about. So in a premenopausal female, they're going to get amenorrhea and galactorrhea. Now, it's a little bit trickier with postmenopausal females because they rarely will have galactorrhea and most are asymptomatic. So you can have high prolactin levels in a postmenopausal female and really not know it. Now, men will have decreased libido, they will have infertility, impotence, and potentially gynecomastia, but this is relatively rare. Now, there's no preparation available for hypoprolactinemic states. So if someone doesn't have enough prolactin, we don't have prolactin pills to give them or injections. Now, for hyperprolactinemic states, patients can be treated with dopamine receptor agonists, so D2 receptor agonists, such as bromocriptine and cabergoline. Now, surgery is also a good option to help remove if you have a prolactinoma that needs to be removed, especially if there's other symptoms like headache and double vision, then surgery will often be your curative treatment.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Which pituitary hormones are produced in the posterior pituitary? Come on, this is easy. There are only two. Is that too much for your feeble little mind to remember? Oxytocin and vasopressin. That's it. All the others are produced in the anterior pituitary. How on earth did you ever get out of high school, let alone get into medical school?
Hi, I'm Dr. Mike McInnes. I'm one of the chief educators here at Doctors in Training, and let's go over quick review number 1. First question, which medications have the potential side effects of central obesity, moon facies, and hirsutism? Well, these drugs include ACTH and corticosteroids. ACTH doesn't cause these symptoms on its own. ACTH simply increases the production and secretion of corticosteroids. So it's really the glucocorticoids that will do this. Next question, what is the leading cause of adrenal insufficiency? Well, the main cause, the most common cause of adrenal insufficiency is prolonged administration of glucocorticoids. This only becomes symptomatic when a patient abruptly stops the prolonged course of the steroids. So say they're taking their steroids for a long time for rheumatologic disease or severe asthma or something like this, and maybe they're on the chronic steroids, and they have a big stressor. They didn't stop the steroids, but they have a big stress, such as an MI or an acute illness, and that increases the body's need for glucocorticoids. But the adrenals are shut down, so they're taking their steroids, but now they need a higher dose. They need what we call a stress dose of glucocorticoids. So these are going to be the main reasons that you see adrenal insufficiency from corticosteroids. They're on corticosteroids and they undergo stress, so they need a larger dose of corticosteroids, or they stop the corticosteroids abruptly. Typically, we wean these patients off corticosteroids to avoid this abrupt drop in the corticosteroids to prevent adrenal insufficiency. Next question, what is the primary clinical use of synthetic ACTH or Cosyntropin? Well, this is primarily used to diagnose adrenal insufficiency. So you have a patient who comes in with apparent adrenal insufficiency. They have weakness and fatigue and some weight loss, hypotension, hyponatremia, hyperkalemia, and you want to find out if this patient has primary adrenal insufficiency, where the adrenal glands are incapable of making cortisol and aldosterone, or if this patient has secondary adrenal insufficiency, where the adrenals are fine, but the pituitary isn't producing ACTH. So you give ACTH, and then you check the cortisol level later. Did cortisol rise? If so, then the adrenals work, but they're not getting the stimulatory ACTH signal from the pituitary. So this is secondary or maybe tertiary adrenal insufficiency. If you give ACTH or Cosyntropin and the cortisol fails to rise, that means that the adrenals aren't capable of responding to ACTH. So the problem is in the adrenals. This is primary adrenal insufficiency. So in general, if you think there's some type of deficiency, you're going to do a stimulation test. In this case, a Cosyntropin stimulation test. If you think there's an excess, such as cortisol excess, as we see in Cushing's disease, you're going to do a suppression test. And in that case, you would do a dexamethasone suppression test. So if you have excess hormone, you try to suppress it. If you have insufficient hormone, you try to stimulate it. That's just a general principle for working up these endocrine disorders. Next question. A male patient with watery diarrhea is diagnosed with a VIPoma, a tumor that's producing vasoactive intestinal peptide. What medications can help decrease VIP secretion and thus decrease his diarrhea? Well, the medications you might reach for include Octreotide and Lanreotide. These are analogs of somatostatin, and somatostatin basically shuts down production of GI hormones, including VIP. So if you give Octreotide, you give somatostatin, you're going to shut down production of VIP and treat the patient's secretory diarrhea. Next question, a patient has prostate cancer. Would a gonadotropin-releasing hormone be used in a continuous fashion or in a pulsatile fashion to treat his cancer? Well, remember how the hypothalamus stimulates the pituitary to produce the gonadotropins. The hypothalamus releases GnRH in a pulsatile fashion, and prostate tissue grows in response to testosterone. So if you treat prostate cancer, you're trying to reduce testosterone. So you do that by suppressing testosterone release, by giving not pulsatile GnRH, but continuous GnRH. The continuous GnRH is going to suppress LH and FSH, and that in turn suppresses testosterone production. Next question. Which classification of medications can cause ovarian hyperstimulation? Well, these are the gonadotropins. They are stimulating the ovaries. Specifically, FSH, follicle-stimulating hormone, is going to stimulate ovarian follicles. It's pretty obvious from the name. Next question. A 50-year-old female complains of blurry vision, amenorrhea, and headache. What is the most likely diagnosis? Well, the clue here really is the amenorrhea. This is most likely going to be caused from prolactinoma. Because this tumor is also causing neurological symptoms, so it's causing headache, it's causing blurry vision. This lesion needs to be excised. The vision and headache are mass lesion effects. It's not caused by the prolactin, it's caused by the pituitary adenoma that's producing prolactin. It's also pressing on the optic chiasm, and it's increasing intracranial pressure, so it's leading to headache. The prolactin, however, causes the amenorrhea. Next question, what commonly used psychiatric medications can cause hyperprolactinemia? Well, these are antipsychotics, the neuroleptic drugs. Their primary mechanism of action is to block dopamine in the central nervous system. Remember, dopamine is the primary inhibitor of prolactin, so if you remove the inhibitor by blocking dopamine, you're going to increase prolactin. And the last question, what is the primary clinical use of the gonadotropins? Infertility. FSH stimulates follicles, so you can use this also for external sexual maturation. You give FSH and LH to increase gonadal hormones such as estrogen or testosterone and therefore cause sexual maturation. So that's it for this quick review. Let's go back to Dr. Lewis.
So let's switch gears to the posterior pituitary. We've been talking about the hypothalamus and the anterior pituitary. Now there's a couple of important drugs in the posterior pituitary. So in general, unlike hormones of the anterior lobe, the two medicines we're going to talk about, vasopressin and oxytocin, are produced in the hypothalamus, but then they're stored in the posterior pituitary waiting for a signal to be released. So even though the hypothalamus is involved, it's not directly stimulating or inhibiting. It's basically just producing and then storing it in the posterior pituitary. So let's first talk about oxytocin. Now it's only used in obstetrics. So it stimulates uterine contractions to induce or reinforce labor. Now this is an IV preparation. Also, you can use this medication to promote lactation, but this is just the nasal spray version, not the IV version. Now it can also be used to decrease postpartum bleeding. So after a woman has her baby, sometimes we give oxytocin to help tighten up the uterus and decrease bleeding. Now, adverse effects. So you can get fetal distress due to excessive stimulation of contractions. Uterine rupture can happen. Usually this is a higher risk with someone who's had a previous C-section, so we try not to use oxytocin on patients who have had C-sections before. Hypotension and water retention are also rare but can potentially happen with oxytocin. Next, let's talk about vasopressin, also known as antidiuretic hormone or ADH. So vasopressin will bind in the kidney to V2 receptors, and this will increase water permeability and resorption in the collecting tubules. So you're keeping more water in the body. It has some vasopressor effects, and this can be used in helping to control bleeding due to esophageal varices or bleeding in colonic diverticula. This is the primary treatment for diabetes insipidus due to ADH deficiency. It can also be treated in von Willebrand's disease and can promote the release of von Willebrand factor from endothelial cells. Adverse effects include headache, nausea, hyponatremia, and seizures. Now, desmopressin is very, very similar to vasopressin, but it has little activity on V1 receptors and causes less vasoconstriction. So where you might use the vasopressin to help with some of the bleeding disorders, you wouldn't with desmopressin. Now, it's the preferred treatment for diabetes insipidus, more so than the vasopressin. Oral forms can be used for nocturnal enuresis. The nasal form is contraindicated. Previously, we were using nasal forms to help with nocturnal enuresis in children, but it's now contraindicated because of severe hyponatremia. Next, let's move on to our next category, thyroid hormones. So in general, the thyroid gland is responsible for the regulation of growth, development, temperature, and metabolism. There's two major forms of thyroid hormone. Triiodothyronine, or T3, is the most active form, and the other is thyroxine, or T4. Now, if you're deficient in thyroid hormone, you'll have fatigue, cold intolerance, bradycardia, a deep voice, mental slowing, and weight gain. The most common cause is due to a thyroidectomy. So if your thyroid is taken out for any particular reason, you're generally going to have low thyroid levels. The other most common medical reason is Hashimoto's thyroiditis. Now, what's the opposite? Excessive thyroid. So what are you going to get? Well, you're going to get tachycardia, heat intolerance, anxiety, insomnia, weight loss, and a tremor. And now the most common cause of that is Graves' disease. So these hormones contain about 60% iodine. The daily recommended iodine intake is about 150 micrograms, and the thyroid gland uses about 75 micrograms of iodine a day. So how do we regulate our thyroid? So thyrotropin releasing hormone, or TRH, is secreted by the hypothalamus, which then travels to the anterior pituitary. So hypothalamus, anterior pituitary. TRH will then stimulate thyroid stimulating hormone, or TSH. So TSH stimulates an adenylyl cyclase-mediated mechanism in the thyroid cell to increase the synthesis and release of T4 and T3. The T3 and T4 can act in a negative feedback to the pituitary to block the action of TRH, and in the hypothalamus to inhibit the synthesis and secretion of TRH. TSH can also be suppressed by dopamine, somatostatin, and glucocorticoids. So in the plasma, 0.04% of T4 and 0.4% of T3 exist in a free form. The rest is bound to protein, which is called thyroxine binding globulin, or TBG. Now T4 and T3 dissociate from thyroid binding proteins in order to enter the cells. There, T4 is deiodinated to T3, so T4 goes to T3, which is the more active form. So these medications are orally administered. Food, calcium, and aluminum-containing antacids can decrease the absorption of T4, but not T3. Now, what type of preparations do we have? Now, we're treating hypothyroid state, so people who don't have enough thyroid hormone for whatever reason. So there's a synthetic form called levothyroxine, and this is T4. Now, there's also leothyronine, which is a T3 synthetic medication, and then there's one called Leotrix, and this is a T3-T4 combo. There's also an animal origin, or desiccated thyroid. So it's just thyroid that's ground up from animal origins. So T4 replacement is generally recommended over T3 replacement because it has a longer half-life, which permits once daily dosing. It's also got a lower cost, and it's easy to check levels in the laboratory when using only a T4 replacement treatment. T4 is given once daily, and a steady state is generally achieved in 6 to 8 weeks. And this is important. If you're adjusting your thyroid hormone, you don't want to give it to them and then check it in a week. There won't be a successful steady state at that point. You have to wait that 6 to 8 weeks. Now, T3 is more potent, but it requires multiple daily doses. It's difficult to monitor and has a greater chance to cause a cardiotoxicity. So we generally want to stick with the T4 treatments. And it doesn't really matter because T4 is ultimately changed to T3 in the cells anyway. So what sort of adverse effects do we see with the thyroid replacement medications? Well, the toxicity is directly related to the T4 level, and you'll see symptoms similar to hyperthyroidism. So as we said before, you'll see nervousness, heart palpitations, heat intolerance, tachycardia, weight loss. And in elderly patients and those with coronary artery disease or multiple coronary risk factors, you need to be very conservative. Thyroid hormone will increase myocardial oxygen demand. And this can also be associated with a small risk of inducing cardiac arrhythmias. More common, you'll see AFib or atrial fibrillation. You'll induce chest pain, and very occasionally you'll even induce myocardial infarction, especially in these older patients. So let's talk about anti-thyroid agents. So hyperthyroidism, so you have increased serum levels of thyroid hormone, you have decreased TSH, and that's a good test question. If someone comes in and has their TSH checked and it's low, well, sometimes you can be tricked into thinking, well, if the TSH is low, that must mean their thyroid level is low. Well, that's the opposite. So decreased TSH means high thyroid. Often this can be caused by Graves' disease or a toxic adenoma. Now, the treatment is first removal of thyroid by surgery. So if you're having major problems with too much thyroid, then you can surgically remove the thyroid to prevent it from secreting more hormone. Now, you can also do this medically as well through radioactive iodine. So 131 iodine can be orally taken, and it's rapidly absorbed and concentrated in the thyroid. And destruction occurs over a few weeks. Now, it's also painless, so it's not like you're having something dying off your neck while you're taking radioactive iodine. It always sounds very dramatic that I'm taking radioactive materials into my body. So next, you can also inhibit thyroid hormone by inhibiting thyroid hormone synthesis. And these medications are called the thiamides. And Propylthiouracil, or PTU, or Methimazole are two examples of this. Now, they act to block the thyroid peroxidase catalyzed reactions, and it blocks iodine organification as well as blocks coupling of the iodotyrosenes. Now, PTU, more than Methimazole, can inhibit the peripheral deionization of T4 to T3. So remember when the cells take in T4 and T3, the T4 is, an iodine gets cleaved off of it and it changes T4 to T3. So PTU can inhibit that process. So it can block the synthesis, but not the release. So it takes about 3 weeks before the stores of the T4 that are already in the thyroid to be depleted. Now, some adverse effects, you can get agranulocytosis, a rash, and edema. Next, let's talk about thyroid storm or thyrotoxicosis. Now, patients with severe and life-threatening thyrotoxicosis typically have an exaggeration of the usual symptoms of hyperthyroidism. So cardiovascular symptoms include tachycardia to rates that can exceed over 140 beats per minute. Patients can also have problems with congestive heart failure because you're just not having enough filling time because of the rapid heart rate. Hyperpyrexia is common. Temperatures of 104 to 106 are quite common. Agitation, delirium, psychosis, stupor, or even coma can be common. And some will consider that these symptoms need to be present for the diagnosis to even be made. Patients will also have severe nausea, vomiting, or diarrhea, and even hepatic failure with jaundice can occur. Although thyroid storm can develop in patients with long-standing untreated hyperthyroidism, it's more often precipitated by an acute event. These events include thyroid or even non-thyroid surgery, trauma, infection, or an acute iodine load. So what are we going to use for these patients? Because this can be a life-threatening situation. Well, first you want to go to the beta blockers. You want to block the sympathetic stimulation by the thyrotoxicosis. You want to decrease the tachycardia that can cause major CHF and even cause death. Propranolol is the most studied beta blocker for thyrotoxicosis, but you can also use metoprolol or atenolol. Now, these medications will cause clinical improvement, but it doesn't do anything to affect the hormone levels. So you're also going to want to use PTU or Propylthiouracil or Methimazole to help suppress this excess hormone that's circulating through the body. Next, let's talk about iodide. Now, iodide will inhibit hormone release from the thyroid. Now, it's very rarely used today, except in potentially fatal thyrotoxic events, like we just discussed earlier. But even then, we try these other medications first before we go to iodide. Now, sometimes they are used prior to surgery because it can decrease the vascularity of the thyroid gland. So this can help potential thyroidectomies. It can also help prevent thyrotoxic storms as well.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Well, well, look what the cat dragged in.
Hey there, sport.
Hey there yourself, good looking.
Well, now that Paula's libido is here, let's get started. What is the definitive therapy for hyperthyroidism caused by Graves' disease?
Wow-wee. That's like an 18-karat doozy there, Simon. Gotta be thyroid ablation, though. Yep. Either surgical thyroidectomy or, more commonly, ablation with radioactive iodine.
Right, you are.
Hi,
That
Doc.
was just wonderful.
Why, thanks, Dollface.
Yeah, I dig your style. Hey, why don't you try this one on for size? What two medications can be given to inhibit synthesis of thyroid hormone in patients with hyperthyroidism?
Inhibit thyroid hormone synthesis.
Well, well, ring-a-ding. Looks like your one-way express to stardom just got derailed.
Cool it, Buster. I'm just getting warmed up. The two drugs that inhibit thyroid hormone synthesis are Methimazole and Propylthiouracil.
And which one blocks the peripheral conversion of T4 to T3?
Propylthiouracil, otherwise known as PTU.
Oh. Nice going, Ace.
All right, let's go over the answers to quick review number 2. The first question, why is the nasal form of desmopressin not used in children for the treatment of nocturia? Well, the reason is hyponatremia. Remember, desmopressin is the same as ADH. And there's this syndrome of inappropriate ADH, or SIADH, which typically causes hyponatremia. So if you give desmopressin, you can actually cause some hyponatremia. Now, you can sometimes still use the oral form of desmopressin for nocturia, but most patients will get nocturia again once they stop the medication. Usually, we're going to treat nocturnal enuresis, or bedwetting, using an enuresis alarm. It's shown to be much more effective for long-term enuresis control. Next question, what is the difference between central diabetes insipidus and nephrogenic diabetes insipidus? So this is important to understand, and it's pretty easy to understand if you can just remember a couple of key facts. Central diabetes insipidus, or DI, is due to insufficient production of ADH. So you get excessive urination, which is what the word diabetes means, excessive urination, and you get dilute urine. That's typical of any type of diabetes insipidus. So in central DI, you're not making enough ADH. You can treat central diabetes insipidus with desmopressin, that synthetic antidiuretic hormone. You're correcting the ADH deficiency by giving ADH. Pretty obvious. Now, nephrogenic diabetes insipidus is very different. In nephrogenic diabetes insipidus, the pituitary is making vasopressin, or ADH, but the kidneys are not responding to it. The kidneys are insensitive to ADH. So this is a kidney problem. This is a nephrogenic problem. It's nephrogenic DI. So you get the same symptoms. You get excessive dilute urine. But what happens if you give ADH? Well, nothing happens. The body's already making plenty of ADH. The kidneys aren't able to respond to it. So you treat nephrogenic diabetes insipidus not with ADH, but with a thiazide diuretic. This is going to help the patient put out a more concentrated, high electrolyte urine. Next question. A G2-P1 woman whose first child was delivered by cesarean section is now attempting a trial of labor. Why wouldn't you want to augment her labor with oxytocin? Well, just in case you haven't come across this terminology yet, G2-P1 means gravida 2, para 1, meaning she's been pregnant twice, but she's only delivered once. So this is a woman who is pregnant with her second child. She had a C-section the first time, and now she's going to try labor, which is something a lot of physicians will try, to try a vaginal birth after cesarean, or VBAC, VBAC. So this woman's going to try labor. Well, why wouldn't you want to give her oxytocin? Well, this oxytocin is going to stimulate uterine contraction and may increase her risk of uterine rupture. So you don't want to overstimulate the uterus by giving oxytocin after a C-section. Next question. A female patient with hypothyroidism is receiving levothyroxine. Her TSH is checked and is found to be abnormally high. How should you adjust her medication? And how soon should you recheck another TSH? So the answer to how are you going to adjust your medication, you have to know, what does a high TSH mean? Well, high TSH means that the patient is not receiving enough levothyroxine, whether endogenously or exogenously. So you have to remember that TSH varies opposite of the thyroid hormone levels. So a patient who has too much thyroid hormone, or hyperthyroidism, is going to have a low, suppressed TSH. A patient, in this case, who is receiving not enough levothyroxine is going to have high TSH. So if TSH is high, this means the patient needs a higher dose of levothyroxine. So you're going to increase the levothyroxine dose. So the second part of the question, how soon should you recheck another TSH? Remember, it takes 6 to 8 weeks for the levothyroxine to sort of equilibrate and reach a steady state in the body, and for that TSH to come down appropriately. So you don't want to put the patient on a higher dose of levothyroxine and then recheck TSH again in a week. It's not going to have changed enough. You want to wait 6 to 8 weeks. I usually wait 6 weeks and then recheck the TSH and see if it's come back down to the normal range. Next question, what are the characteristic ophthalmologic manifestations of Graves' disease? Well, the characteristic manifestations in the eye are proptosis, or this bulging of the eyes, which can be pretty pronounced and pretty amazing to see, and then also periorbital edema. Now, it's important to know, hyperthyroidism does not cause proptosis. I'll say that again because it's important. A lot of people don't really get this at first. Hyperthyroidism by itself does not cause proptosis. It's not the thyroid, the high levels of T4 and T3 that's causing the proptosis. Graves' disease causes this Graves' ophthalmopathy because the antibodies are building up and you're getting edema and increased tissue in the tissue behind the eye, so it's pushing the eyeballs out and causing proptosis. So Graves' disease causes ophthalmopathy and it causes hyperthyroidism, but hyperthyroidism by itself does not cause proptosis. So you can give a patient a huge dose of levothyroxine and get their TSH really suppressed. It's not going to cause that typical Graves' ophthalmopathy. It's not the hyperthyroidism, it's the antibodies, it's the Graves' disease itself. Next question, why should you start with a very low dose of thyroid replacement medication in elderly patients? Well, elderly patients are much more likely to have cardiac complications when you give them thyroid replacement. They can get tachyarrhythmias, they can get atrial fibrillation. So general principle, start low, go slow. Start with a very small dose of levothyroxine, maybe 25 micrograms daily, or sometimes that'll be written out as 0.025 milligrams daily. Do that for 6 to 8 weeks, recheck, and if they need a stronger dose, then you bump that up from 25 micrograms to 50 micrograms and so forth. So start low, go slow. Next question, why wouldn't a patient immediately feel the antithyroid effects of Propylthiouracil, or PTU? Well, PTU blocks the synthesis of new thyroid hormone, but it doesn't have any effect on the thyroid hormone that's already been created, that's already been formed and stored. So the thyroid makes T4 and stores it and then releases it over time. PTU is not going to affect all that stored thyroid hormone. So it takes about 3 weeks for the T4 stores to be depleted. And then the patient on PTU is not going to be making as much thyroid hormone. So then they'll start to feel it. Next question, what are the symptoms of thyroid toxicosis or thyroid storm? The symptoms include tachycardia, hyperpyrexia or high temperature. Sometimes that's described as heat intolerance. The patient just feels really uncomfortable. You'll ask the patient, do you ever go outside in the dead of winter wearing nothing but shorts and t-shirt? And if they say yes, that's probably because they have way too much thyroid. They can also get agitation. They can get delirium. They can get coma. They can get psychosis. So a lot of really bothersome CNS effects. They can have nausea and vomiting. They can also have hepatic failure. So thyroid storm is very rare, but you need to be able to recognize it because it's very dangerous. And the last question, what 2 classes of medications are used to treat thyroid storm? So you're going to treat symptomatically with beta blockers because that's going to reduce the effect of the thyroid hormone on the heart and reduce some of that tachycardia. You're also going to treat the thyroid with one of the thioamides, either PTU or Methimazole. So that's the end of the quick review. Now let's pause the video, complete the end of session quiz, and then we'll go over those answers. All right, let's go over the answers to the end of session quiz. First question, how does the release of hormones from the anterior pituitary differ from the posterior pituitary? Well, the posterior pituitary hormones are produced in the hypothalamus and then stored in the posterior pituitary. Anterior pituitary hormones are not stored. Next question, why are the hormones of the anterior and posterior pituitary not given orally? Well, these are proteins. These are polypeptides. Your body is very good at digesting proteins in the GI tract. So you absorb individual amino acids from the proteins that you've digested. You're not absorbing functional proteins. So peptide drugs or protein drugs, most hormones, or a lot of hormones that are protein drugs, have to be given as IV or IM injections. Or you can give other parenteral routes, maybe a hormone nasal spray, such as the nasal spray of vasopressin. So you can give it parenterally, but you cannot give them orally because they're proteins. Next question, what hormones are released from the anterior pituitary? The hormones are TSH, ACTH, LH, FSH, GH, and prolactin. Next question, what hormones are released from the posterior pituitary? The hormones are oxytocin and vasopressin. Next question, what medication should be used given the following scenarios? So the first scenario is treatment for acromegaly or secretory diarrhea caused by VIPoma. Well, the medication you might use for this would be somatostatin. Somatostatin is going to suppress growth hormone, which is the problem with acromegaly. It's also going to suppress production of vasoactive intestinal peptide, or VIP, which causes the secretory diarrhea in a VIPoma, or a tumor that releases VIP. Next scenario, treatment of central diabetes insipidus. We already mentioned this. You treat central diabetes insipidus by giving vasopressin, or ADH, or in this case, you might use desmopressin, which is a synthetic version. The next scenario, treatment of hypothyroidism. You're going to treat hypothyroidism with thyroid hormone, or levothyroxine. Treatment for prostate cancer, endometriosis, and precocious puberty. You're going to use a GnRH agonist, such as Leuprolide or Goserelin. Now, obviously, a man would have prostate cancer, a woman would have endometriosis, so it's not like you're going to have the same patient with all of these conditions. But all these conditions can be treated with a GnRH agonist. Next one, treatment of thyrotoxicosis. You're going to treat with a beta blocker to suppress the tachycardia, to treat the tachycardia, and then you can use a thioamide such as PTU or methimazole to suppress thyroid hormone production. Next one, to elicit sexual maturation in males without gonadotropins, you might use HCG or human chorionic gonadotropin, which will actually stimulate semen and sperm production in infertile males. The next one, to induce labor or to promote ejection of breast milk, you can use oxytocin for this. And the last one, to differentiate between primary and secondary adrenal insufficiency. We talked about this earlier. This would be ACTH. Next question, what are the synthetic C analogs of growth hormone inhibiting hormone that are used in the treatment of acromegaly? Well, these analogs include Octreotide and Lanreotide, so you need to be aware of those. Next one, what hormone has the following actions? So, which hormone stimulates bone and muscle growth? Well, this is growth hormone. Which hormone stimulates milk production and secretion? This is prolactin. Which hormone stimulates milk secretion during lactation? This is oxytocin. So prolactin stimulates milk production, and then you think of oxytocin to eject the milk. Which hormone is responsible for female secondary sex characteristics? This is FSH, or follicle stimulating hormone. Which hormone stimulates the adrenal cortex to synthesize and secrete cortisol? This is ACTH. Next one, which hormone stimulates follicle maturation in females and spermatogenesis in males? This is LH, or luteinizing hormone. And then finally, which hormone stimulates the thyroid to produce thyroid hormone and to take up iodine? This is thyroid stimulating hormone, or TSH. Next question, what are the therapeutic uses of growth hormone inhibiting hormone? You can use this for pituitary excess, such as acromegaly, thyrotropinoma, or an ACTH secreting tumor. So you're going to suppress the pituitary with this hormone. You can use it for GI endocrine excess, VIPomas, Zollinger-Ellison syndrome, carcinoid syndrome, glucagonoma, insulinoma. These drugs are going to completely block, or at least dramatically reduce, intestinal hormone production. You can use it for certain diarrheal diseases. You can also use it if you need to reduce the splanchnic circulation, such as a patient who has portal hypertension, or they've got cirrhosis, and they've got varices in the esophagus that are bleeding. You need to reduce that splanchnic circulation, reduce the bleeding, or if you've got bleeding peptic ulcers and you want to reduce the bleeding, you can give octreotide for that. Next question, what are the therapeutic uses of desmopressin? We already mentioned that desmopressin is used to treat central diabetes insipidus, and it can also be used to treat nocturnal enuresis. Again, you want to use that orally in children, not nasally. And the last question, what is the most common clinical use for iodide? Well, iodide, again, can be used prior to surgery to decrease the vascularity of the thyroid gland so that when you operate, you don't have as much bleeding. So that's the end of our end of session quiz. Thank you very much.